Dr. Ken Landa. Let's talk about screening mammography and breast cancer diagnosis and what a dense breast means. When we come back in part 2, we're going to discuss 3D mammography or tomosynthesis. Sweeping the country right now, is it of help? Breast cancer is a very common condition. It's estimated that about 240,000 women will be diagnosed this year. Probably around 40,000 women, unfortunately, will go on to succumb to breast cancer. We know that breast cancer is a disorder that becomes increasingly frequent with increasing age, while women between the ages of 40 and 49 have been sensitized to the diagnosis and sensitized to the need for having mammography on a regular basis. The evidence suggests that it's those women who are in their 60s who are at greatest risk. And as a matter of fact, the average age of diagnosis in the United States for breast cancer is 64. Average age of death is 68. Now, the statistics on breast cancer haven't really changed all that much from the 1970s. We're making the diagnosis more frequently, and there's a little benefit on the death side, but it still isn't anywhere near what it should be. We know that not all women are created equally as far as breasts are concerned. We know that certain women inherit a gene, a genetic abnormality, either BRCA1 or BRCA2. Those are two genetic abnormalities, two gene abnormalities. When your grandmother has breast cancer, your mother has breast cancer, you better get tested because you may well harbor this gene that increases your risk for breast cancer. We know that those rare women who get radiation therapy to the chest wall when they're young, they have an increased incidence of breast cancer. Breast cancer used to be much more common in white women than black. At the present time, the incidence seems to be neutralizing between the races. However, women of color still seem to have an increased incidence of death because of breast cancer, apparently because the tumors that they develop are increasingly aggressive. Now, it's important to realize that with mammography, we make the diagnosis of small breast cancers much more frequently. And the question is, does that give us any benefit? Or is the situation somewhat akin to what's happening with prostate cancer? With prostate cancer, we do the PSA is abnormal, we do the biopsy, we find the cancer, we treat the cancer, but the death rate doesn't seem to change. Well, if we find a small breast cancer and we treat it, are we really performing a service to women, or are we finding the wrong kind of tumors? Are we finding the tumors that aren't more aggressive? And that's an issue that we have to face right now, because more mammograms mean more diagnoses, which mean more therapy. But unfortunately, the death rate isn't going down nearly to the frequency with which we're making the diagnosis. Well, there's another issue. We make the diagnosis of a precancerous condition, a potentially precancerous condition known as ductal carcinoma in situ. Ductal carcinoma in situ is not cancer. But the fact that the word cancer is in the name scares a heck of a lot of women. And right now, this condition that may or may not go on to develop breast cancer is treated as aggressively as if it were an invasive tumor. So that's a major problem. Here's another problem. A study was performed looking at 16 million women in the United States. They looked at the different counties. Almost 550 counties were evaluated. In some counties there were a lot of mammograms, other counties relatively infrequent mammograms. Those counties where the mammograms were frequent, well, the diagnosis of breast cancer was made anywhere between 16 and 25% more often for every 10% more screening that was performed, but there was no change in the death rate. Well, that's not so good. We're doing more mammograms, making more diagnoses, but we're not changing the death rate. Something is screwy here. Well, a study was begun, and in 2009, the United States Preventive Services Task Force presented preliminary findings. And this is the group that's charged by Congress with making recommendations. So when you talk about how often you should be screened for this or that, it comes right from the United States Preventive Services Task Force. Well, what they said in their initial report that really scared the people in Congress because of political reasons is they said that women of average age and average risk should start mammography at age 50, not at age 40, at age 50, and they should have mammograms every other year, not every year. That's women of average risk. They also said that women over age 74 probably didn't need to have mammograms. Women between the ages of 40 and 49 could, but there wasn't any good evidence, and they suggested that mammograms be between age 50 and 74. Well, actually, when they evaluated the data, it seemed that there was no decrease in benefit, no substantial decrease in benefit, as we go from yearly mammograms to every other year mammograms, but the likelihood of harm was significantly reduced. Yes, the likelihood of harm from mammograms, there is harm, and we'll talk about that. Well, Congress, knowing that that was going to be the official recommendation, and that recommendation was going to be published in 2015, in order to prevent the same controversy that existed 20 years before, when that same panel, looking at the same data, now updated, said women between the ages of 40 and 49 really don't need mammograms. Well, there was a horrendous problem in the Congress, not in science, but in the Congress, of what to do with all the women who were complaining. So the Congress forced the United States Preventive Services Task Force to override their own evidence, their own conclusions. Well, Congress in 2014 passed a rule, passed a law, and said that over age 40, women with private insurance would have to have mammograms covered, no copays, no deductibles, no coinsurance necessary, but women between the ages of 40 and above would be able to have their mammograms covered. Well, sure enough, 2015, the United States Services Task Force said every other year, and women over age 50. And as a matter of fact, what they said, we're talking about average risk women, of course, what they said was that they couldn't show any significant benefit for women between the ages of 40 and 49, and there was no apparent benefit women over age 74. Evidence is relatively sparse, perhaps, but there is no evidence of any significant benefit. Well, that was a major change from what the government expected or the government anticipated. So we have to look around and see, is the United States Services Preventive Task Force, are they out of touch? Well, let's look to the American Cancer Society. American Cancer Society says we should screen for a lot of diseases. What do they say about breast cancer? They used to say that yearly mammography ought to start in women age 40, 40 and above. They've changed the recommendation. They say, let's split the difference. 45 to 54, maybe they'll get yearly mammograms. But after age 54, do it every other year. There's a problem with mammography, as I said. And the problem with mammography is that about 10% of the women are going to be called back for some sort of an abnormality. Now, the abnormality to most women means, oh my goodness, I have cancer, but fewer than 10% of the women called back actually do have cancer. So we have a significant number of people being called back for a relatively small incidence of cancer, and that's what we call a false positive diagnosis. And the likelihood of one of these false positive diagnoses, finding something wrong when actually nothing exists, is much more common in women between the ages of 40 and 49. As a matter of fact, if women between the ages of 40 and 49 have just one mammogram, the likelihood of being called back is 12%. 1 in 8 are going to be told that they have an abnormality, and that abnormality is going to go on to cause other screening, or it's going to go on to lead to a biopsy. But the likelihood of cancer is very, very, very small. And as a matter of fact, a study came out in 2011, and what they did was they evaluated what happens when you take 10,000 women, you follow them for a significant period of time, women over 10 years, starting at age 40, in that age group, the 40 to 49-year-old age group, what's the likelihood of a false positive if they have the mammograms on a routine basis? Well, the likelihood of an abnormality, of being called back, is as high as 2 out of 3. 2 out of 3 women being called back for a diagnosis of breast cancer that's very rare in that age group. That doesn't seem to make any sense. Well, you could reduce the likelihood of harm simply by going from every year to every other year in that age group. Well, first of all, we have the false positive diagnosis. Then we have the problem with further testing. Then we have the problem with all the emotional lability that goes with being told that you have an abnormality. We have the potential for biopsy, potential for scarring. We have the potential for it interfering with life. And then we have, obviously, significant major expense. So with all of that in mind, the mammograms don't seem to be nearly as good as most people believe. The harms of mammography seem to decrease, however, as women grow older. So women who are over age 60 are much less likely to have problems with mammograms, have false positive diagnoses with mammograms, than women who are relatively younger, say between 40 and 49. As a matter of fact, if we compare women 40 to 49 with women 60 to 69, we find that in those younger women versus those older women, the likelihood of a biopsy is going to be exactly the same. On the other hand, the likelihood of cancer is going to be much higher in women who are older. So the false positive diagnosis falls from 12% in women who are between the ages of 40 and 49, so 1 in 8 women being called back, to women between the ages of 60 and 69, it's only 1 woman in 12. Or 8% of women are going to be called back. Well, a lot of people have the idea that mammograms are essential to diagnose, prevent, and reduce the likelihood of dying from breast cancer. So let's look at women, 10,000 women, and let's say we follow them for 10 years. So let's start off at age 40. What's the likelihood of women having routine mammography between the ages of 40 and 49 are going to have the mammogram be responsible for saving their lives? 3 women in the 10,000 are going to owe their lives to the mammograms, and that's the best guess, and that's the highest number. So it may well be considerably less than the 3. In women, on the other hand, between the ages of 50 and 59, the likelihood of the mammogram saving a woman's life in 10,000 women is 8. Again, that's the maximum number. If we look at women between the ages of 60 and 69, now we're talking about maybe 21 lives being saved because of the mammograms, but it tends to fall over age 70, so the number of lives saved is only about 13. And again, those are the best of the highest numbers. Now, unfortunately, in order to save that number of women, say between 60 and 69, to save 21 women, a lot more women are going to have to undergo therapy. So, important thought is that mammograms don't necessarily save lives. What mammograms do is they fit into a pool. Some women are going to be helped. A lot more women are going to be harmed. Society has to place a number on where the benefit and where the risk is, and how much benefit we can have and how much risk we're willing to tolerate. You have to realize that the screening trials are over 30 years old. We've had a significant increase in the type of technology that's available to screen the breast. We have significant increase in the kind of treatment that we have. We've made the diagnosis of breast cancer probably 50% more frequently than we did in the past, but the likelihood of death from cancer of the breast is nowhere gone down by 50%. We used to use the film screening mammography. Now we've advanced to digital mammography, a little bit better probably, but there's a question about how much better. Overall results can be looked at, number of lives saved through reducing the likelihood of breast cancer. We just suggested it's relatively small. The all-cause mortality, what's the likelihood that you're going to live longer because you have a mammogram or a mammogram is diagnosed with breast cancer that's going on to be treated? Well, all-cause mortality doesn't seem to make any difference. Now, we have an issue, and the issue is dense breasts. Dense breasts are harder to evaluate through mammography than non-dense breasts. What's that mean? Well, a dense breast is a breast that contains a lot of glands. And we rate the breast in 4 different categories, from fatty breasts that are non-dense, to breasts that contain scattered fibroglandular tissue, non-dense, to breasts that contain a lot of the glands or are extremely dense, well, those breasts much harder to evaluate. And it's thought that maybe dense breasts are more likely to harbor cancer. Well, how likely is a woman to have a dense breast? Well, dense breasts are more common in young women than in old, but in young women, the diagnosis of breast cancer is much less than it is in older women. And we know that at present, probably about half of women have dense breasts and half of women have non-dense or more fatty breasts. And that's important because, again, we can make the diagnosis of breast cancer more easily in women who have non-dense breasts. So the states have gotten together and come up with a conclusion. What the states believe is that all women, 24 states, those women who have mammograms should be told whether they have dense breasts or non-dense breasts. Well, I'll tell you what, doctors don't know what the heck dense breasts and non-dense breasts mean, and the patient knows even less. So if you have a report that shows that you have a non-dense breast, then you're okay. But if you have a report that says you have a dense breast, does that mean you should go back and get some further kind of screening? Maybe you need some ultrasound or an MRI or maybe some 3D mammography? Is that what it means? Well, there's no evidence to suggest that that really is the answer. What's important to realize is that dense breasts may harbor more tumors than non-dense breasts, but doctors can't uniformly agree on what's a dense breast and what's not a dense breast. And as a matter of fact, you could be diagnosed with having dense breasts this year and non-dense breasts next year, or you could have your screening read by one radiologist and the radiologist says you have dense breasts, and have that same film, same image evaluated by another doctor, and that doctor would say the opposite. So we don't have a precise definition, yet by law, we have to notify women of something we don't exactly know what to do about. Well, with that all as the baseline, I want you to come back and watch us when we talk about 3D mammography or tomosynthesis. Is that really the answer? Is that really the way to go? Well, we'll talk about that when we come back.